For anyone just joining in, we're going to give it a minute or two for other folks to hop on, and then we will go ahead and get started with this session. Hello, too. I'll start. Hello, everyone. Welcome to the Health Equity in Action Libraries, Communities, Opportunities, a summit hosted by the American Library Association Social Responsibilities Roundtable, or SRRT for short. SRRT believes that libraries and librarians must center social responsibility by recognizing and helping to solve social problems and inequities to work for the common good. My name is Alicia Columbell. I will be our moderator for today. I am also joined kindly by Rachel on chat and April as our tech for today. To enable captions, please click more in the bottom right of the screen and then click Show Captions. Our session today will be recorded and the recording will be available on our website within a few weeks. As a kind reminder, please keep cameras off and mics off unless you are a presenter for us today. This session focuses on from data to action, how open source health data platforms can democratize research and empower community advocacy. We have Kim Cinco and Benjamin Hammond with us. Kim is the user experience engineer and project manager for Health Equity Tracker through the Satcher Health Leadership Institute at the Morehouse School of Medicine. And Benjamin is the senior software engineer and team lead for the same. So I'm going to turn it over to our presenters. So thank you for being with us today, Benjamin and Kim.
Hi, it's so great to be here. Yeah, my name is Kim, and I'm joined today by Ben. And as Alicia mentioned, we are with the Satcher Health Leadership Institute at the Morehouse School of Medicine, where we work on a platform called the Health Equity Tracker. I go by the pronouns she, her, and I'll pass it over to Ben to introduce himself.
Hey everybody, Ben Hammond, he, him, and yeah, really excited to share this project that has dominated the last 4 years of my employment at Morehouse School of Medicine. I'll pass it back to Kim and she'll get us started.
So here's how we're going to be spending our time together today. We're going to move through 6 sections covering why data access is a justice issue, what the Health Equity Tracker actually does, how communities are using it right now. We're going to talk a little bit about a workforce equity program called SEED and the very specific opportunity I think that libraries have in all of this, and then some replicable models you can take home. We'll pause in the middle for a live demo by Ben, and we're going to leave a solid 10 to 15 minutes at the end of for your questions and discussion. So let's get into it. I want to start with something that might sound obvious once I say it, but that I think we often gloss over. Health inequities in this country are not a secret. We have decades of research documenting racial disparities in maternal mortality, chronic disease, COVID outcomes, you name it. The documentation exists and the data exists. The problem is that it almost never ends up in the hands of the people that it's actually about. Policymakers are making decisions right now without hearing from communities who are armed with evidence. Advocates go into city council meetings and legislative hearings with personal testimony, which is powerful, but they often don't have the data to back it up. And communities experiencing the worst outcomes have historically had the least access to the information that documents their own reality. That's not coincidence, it's a structural problem, and it has real consequences for who has power in the policy room. So why is the data so hard to get to? There are 4 walls that keep it out of community hands. The first is paywalls. A massive amount of health research lives behind academic journal subscription that costs hundreds or thousands of dollars a year. The people who need that research simply cannot access it. The second is technical jargon. Even when data is technically available, say on a government website, it's often buried in statistical methodology and epidemiological terminology that requires years of training to interpret. It's not written for a community organizer. It's not written for a parent in a neighborhood with high asthma rates trying to figure out why. The third is fragmentation. Federal health data is scattered across dozens of agencies: the CDC, the Census Bureau, state health departments, HHS, all with different formats, different update schedules, different definitions of the same variables. Even trained researchers struggle to piece it together. And fourth, and this is the one that I think really sticks, aggregate data hides disparities. If a national report says that the maternal mortality rate is X, that number tells you almost nothing. You cannot see who is dying. You cannot see where. You cannot see whether things are better or worse for specific communities. You can't see what isn't separated out. Put all four of those barriers together, and you get something that should make all of us uncomfortable. The communities experiencing the worst health outcomes have the least access to data documenting their reality. That creates three gaps that compound on each other: a power gap, where communities go into policy conversations without the ammunition they need; a narrative gap, where in the absence of accessible data, misleading or regressive narratives fill the void; and a policy gap, where decisions get made for communities, not with them, because the evidence isn't in the room. That's the problem we built the Health Equity Tracker to address. The Health Equity Tracker is a free, open source platform that takes federal and state health data, the same data that's currently inaccessible to most people, and transforms it into interactive visualizations that anyone can use. You can find it at healthequitytracker.org. There's no login, there's no subscription, there's no fee. We pull from the CDC, the Census Bureau, the American Community Survey, state health departments, and other federal sources. We cover maternal mortality, COVID-19 outcomes, chronic diseases like diabetes and COPD, and a range of social determinants: poverty, insurance coverage, and the like. And we're serving over 85,000 users a year across all 50 states and US territories. Those users include community health organizations, investigative journalists, public health professors, grassroots advocates, policymakers and their staff, and people writing grant applications for community-based organizations. The goal is simple: get the data out of the databases and into community hands. And it's as simple as completing a sentence. We have this easy drop-down menu. For example, in this graphic, we have investigate rates of, and then you can select HIV, and then it defaults to prevalence, and it defaults to the United States. But you can go down to the state and even to the county level for most of our topics. So the key to what the HET does differently is disaggregation. A national report might tell you maternal mortality rate equals X, and that number is technically accurate, but it flattens everything. On HET, you can break that same data down by race and ethnicity, by age and sex at birth, by geography, down to the state and county level, and by population share, which lets you see not just raw rates, but whether a group is experiencing a disproportionate burden relative to their share of the population. You can look at health inequities over time with our time series data. You can see whether things are improving or worsening in your state. You can download the data directly and use it in a presentation, a grant proposal, a news article, or a testimony. the difference between national maternal mortality rate and Black and Indigenous birthing people in state are dying at 2.5 times the rate of white birthing people, and that gap has widened over the last decade, is the difference between a statistic and a story you can take into a policy room. So just to give you a sense of the platform's reach, 85,000 users annually across all 50 states and US territories, 20 years of maternal mortality trend data, coverage across all 50 states plus DC and US territories. These are not researchers in ivory towers. These are people doing work in their communities, and they're using this data. All right, so let's actually look at it. I'm going to stop sharing my screen and hand it over to Ben.
Move this up. So here we are. This is the Health Equity Tracker, healthequitytracker.org. And you started off, the data is really where we go. There's some other information on the first screen, including a blog with recent news about health equity topics. We're just going to dive right into the data. We presented it with users to just have a quick click if they want to see some interesting visualizations. And also Kim was saying, still in the method, so to speak. We'll just take a quick look at topics. Started in 2020 with the COVID pandemic. The visualizations in the New York Times and many other sources were becoming, extremely popular to look at. It was how people were seeing how COVID was spreading, but lost in all of that excitement around visualizing the data were the inequities baked into who was getting COVID and then who was getting vaccines by race, by age, by sex. And there were some fundamental disparities needed to be addressed. So the Health Equity Tracker was built as part of a grant with Google.org and the CDC Foundation and a number of other grantors, including Morehouse School of Medicine, who now maintains and expands the tracker. So to start off, it was simply COVID-19 and some comorbidities like diabetes and COPD. And then over the years, as COVID has, I don't want to say faded because it's still an extremely big issue for many people, but it's not the sole focus anymore. We've really tried to expand it to cover a number of different health topics, particularly those ones that see massive disparities. So to start off and to give you just a brief walkthrough of what the tracker can do at its most basic level, we are going to look at maternal mortality, which is one of our more recent topics. And Kim will go into some more detail about this, but we were actually able to put this information through the SEED program, which was an open source initiative we started, having early career software engineers contributing to the project and getting mentorship along the way. So as she noted, you can investigate rates of maternal mortality. If you want to skip directly to another specific location, you could go to that state. And then you can, so in this case, it's only ethnicity. If it's another topic, you can change the disaggregation to their demographics like sex at birth, age group, and then sometimes things like disability status, stuff like that. So the first item that we're presented with is the United States, and it's sort of showing you which geographical regions the highest and then the lowest deaths per 100,000. So it's a rate. It's important to note that we do present almost exclusively rates on the Health Equity Tracker so that it's a fair comparison, because obviously certain demographic groups like Native Hawaiian people make it a less a much smaller portion of the population than white people do in the United States. So we're comparing apples to apples, so to speak. So you can see here right off the bat the states that are doing relatively better in terms of new mothers who are dying in childbirth. So that would be New England, the central Midwest, the Lake states, and the western West Coast state there. And then it's pretty clear the opposite. You can see right away the states that are facing disproportionate maternal mortality, and that's in the South. And that's tied in. Unfortunately, this pattern is present almost all of our topics that we represent, where the states in the Deep South face glaring disparity. And that's a lot of the work that Morehouse School of Medicine is doing more broadly beyond the Health Equity Tracker. I'll also make a really big point to highlight the territories, as Kim mentioned. Those have very disparate racial makeups. Each territory represents a different racial group pretty strongly, and thereby faces a lot of these same health disparities. And a lot of trackers that are doing some similar data tracking, it's hard to find the territory data, or it's a little bit inconsistent. So the tendency with some of these platforms is to kind of brush the data under the rug if it doesn't fit the narrative or it's not clean and easy. And we really try to go the opposite direction. We try to expose data gaps, and we'll go into that a little bit later as well, some other ways we do that. This also, by displaying the data, it also works as a way to down into particular communities. So Morehouse School of Medicine is in Georgia, you dive in and you see rates per state.
Ben, could you just repeat the last bit? You were kind of out of, it was hard to hear.
Sure. Yeah, let me know. I can try to relocate if the connection is not great. So when we're looking at the national view, you are able to put in on the map showing you the details and view individual states. And at some topics, you are able to view the county level. Should I relocate in my house? Is my connection okay?
Yeah.
You're getting some indication, that it's getting a little hard to hear. It's only every other word. So if you have that option to make it a little clearer, that might be helpful.
Yeah, I'll try that. Sorry about that.
And maybe turn off your video too. That might help. It's not a live webinar without technical difficulties, y'all.
Mhm.
Oh, good. We're doing very well in time. And thank you for your patience to everybody, but this is such crucial information. We don't want anyone to miss out on what Ben is saying.
So I'll speak for a minute more, and then you can I'll check in and see if the connection is any
You're
better.
actually so much clearer that
Yeah,
way. So
that's a lot better.
Okay, perfect. I can't promise that my 1.5-year-old might come in the door at any point. If you hear somebody chatting in the background, that's her. So what I was saying before, I'll start. Basically, you can advocate to each of the states and see the similar information that you see at the national level here. You can drill down and see it at a state, and in some cases, a county level. Again, like Kim was saying, the real goal is it's one thing to see a rate for a disease for the nation as a whole, but that doesn't really give you the detail about how that condition might affect your community, where you live precisely, the people that live in your neighborhood, what you look like, who, where you're going, what age you are, all of that. So we'll skip through past the map. There's also sort of fundamental to the health equity tracker, and I know this is a major issue in the library community, is accessibility. So we have really tried to bake in making this data accessible regardless of your ability to see the site. If you're using a screen reader instead of a normal visual web browser, you still should be able to access all of this information. So we have a few different ways we do that, but one of it's right here, and you can just, I'm sorry, this is on a different. Basically, if you're using screen reader, it will read out these details to you each state as you're going through. And then this feature can also kind of hone in on some of the most important details here, which is which states in this case are having the highest and the lowest rates. And it just really brings it into focus which geographical areas are suffering and also which ones are seeing success. So as we move beyond that part, this is one that's worth looking at for a minute. This is the rates over time, as Kim mentioned, by race. So each of these bars represents a different race. And there's a couple important things to take away here. If you just look at the all, you can say it's striking. The rate of maternal mortality has gone from 14 out of 100,000 new mothers dying in childbirth or afterwards from childbirth related causes. And that was in 2000. And it's gone all the way up to 32 in 2019. So it's doubled over the last 20 years. However, hidden sort of within that, if just looking at the overall rate, you can see that all along, Black and African American mothers have already suffered double the rate to begin with, 30 per 100K versus 14 or 15. And then as it's risen for all people, it's continued to be disproportionately high for Black. And then you can also see Indigenous mothers, it's also extremely elevated. So this is a really important way to be able to see the layout of how it's affecting different people and then which communities it's getting better or worse. And in this case, it's getting worse for almost everybody. Very mild improvement at the end, and that may just be statistical. This is the other drawdown I was kind of mentioning before with the accessibility. It's really hard to represent this type of graphic. A screen reader, what we do is we try to get a table with the underlying data, and that allows you to sort of check your work. If you think, oh, this link it's about 21, you can really go down and cross-reference it. And then also an unsighted user would be able to navigate this table and understand which data is happening and where. The bar chart is pretty standard. It's representing the same information that we're seeing. That last chart over time, but it's a snapshot. I'm not going to go super into detail other than to just point out the glaring clarity that is present on all these. And then the next one I'll go into, it's worth another minute to unpack because it's a different way of looking at the same information. You have, instead of looking at the rates where we're saying per 100,000 of these individual types of people, this is how many are suffering. Instead, we're inverting the calculation. We're saying of all of the maternal deaths that were recorded, what share of those belonged to each demographic group? Then how does that compare to the population large in the percent of that population? In other words, you can see that of the population, Black and African American people make up roughly 12% of the population. And compare that to, of all the maternal death, almost a third of those occur among Black and African American new mothers. So that's just another way to show this disparity that Black, Hispanic, and Indigenous are far overrepresented when you talk about deaths versus per shared population. And then the inverse here, um, in America, roughly 60% are white, and only 15% the maternal deaths.
Ben, you're
So
starting to break up a little bit again.
I'm not sure what else I could do, so I guess I'll just try to speak slowly and
I think when you
hopefully you
speak
don't.
louder, it works a little better.
Okay, that sounds good. So I was going to touch on one other thing. I think the live demo is almost done, and Kim, maybe you can fill in any gaps, and I can also answer any questions in the chat if the connection's poor. In this case, I did want to touch on um, some of the other topics, including the that really emphasize missing data. So in this case, we'll look at this is kind of a unique topic that we show that's more structural in nature. This is women serving in legislative office. As we know, women are historically underrepresented in positions of power, particularly government. And so if you look in here, what we're looking at is the breakdown of women serving on state legislators. So people making the laws that can affect policy that has a direct impact on conditions like maternal mortality. Have a similar map. All of this data might be the same in nature, but we all represent those with an unknown race. And it's really interesting. You can see the share of unknown going down over time as data collection did get better. And so we're able to be more aware of the race of these women serving in government. And then the last thing I'll show here is a map where you really see specifically each geographic area, how unknown that racial data is. So in this case, you can see that these states only report the race of their legislators. And in this case, a lot of the territories, we have no indication or very little indication what the race is of the people that are representing and making the laws. I'm going to hand it back over to Kim. That's most of what I wanted to cover from the live demo. And apologize for the connection. If you have specific questions, probably the best way is to include them in the chat, and I can address those via chat.
Thank you so much, Benjamin. And then Kim, did you toss back to you? Did you have additional information to add?
Yeah, just wanted to close it out with the role of libraries. So everything you just saw and kind of heard is the result of some deliberate choices that we make in how we build this platform. Uh, we follow with web content accessibility guideline compliance. And I don't know if you caught, but Ben was trying to show the way that we accommodate for screen reader compatibility for non-sighted users, because accessibility is not a nice to have for us, it's a requirement. Communities without desktop access use the HET on their phones, so mobile responsiveness matters. Plain language is a core design principle, and every new feature we build goes through feedback loops with community partners, not a one-time consultation at the beginning, but ongoing co-design. These aren't just the technical details, they're political choices about who the tool is actually built for. So let me get specific about what data in community hands actually looks like. Community health organizations are incorporating HET visualizations into city council and state legislature presentations when they're advocating for maternal health funding. They're not just saying, we have a problem. They're showing up with 20 years of trend data and state and county level comparisons. Grassroots organizers are using disaggregated data in community forums to demonstrate concretely why their specific neighborhood needs specific resources. Not a general asked, a data-backed case. Investigative journalists are citing HET in health equity stories that drive policy discussions and public health awareness at a national level. Public health professors are integrating HET into curricula. Community health worker training programs are using it to ground learners in local data. And community-based organizations are including HET data in grant applications to demonstrate need and justify resource requests. That last one is huge. Funders want to see evidence. HET gives smaller CBOs access to the same data infrastructure that larger institutions have. And I want to sit with the maternal mortality data for a moment because I think it illustrates why this work is so urgent. Maternal mortality rates have risen dramatically over the last 20 years, and the gap between racial groups has widened significantly. And within that already alarming picture, Black and Indigenous birthing people are dying at 2.5 times the rate of white birthing people. That gap is not explained by income alone or insurance coverage alone. Research consistently shows it persists across socioeconomic levels. It is a product of systemic racism in healthcare. When community advocates can show up with that 2.5 times figure, not as an abstract claim, but as a data visualization with a source, with trend lines, with state level context, that changes what's possible in an advocacy conversation. 85,000 users annually, all 50 states, US territories, coverage in major national media outlets, integration into public health curricula at multiple universities, an international open source contributor community, continuous feedback from partners shaping every new feature. This is a platform that's working, and it's entirely free and open source. I want to shift for a moment and talk about something that I think is under discussed in health equity work. Who is actually in the room when these tools get built? Tech careers are gatekept in a way that systematically excludes the people who most understand the communities these tools are meant to serve. CS degree requirements, prior experience requirements that career changers can't meet. And I should know, I was one of them. I worked in social work. I worked as a probation officer, social worker. And then when I transitioned into software engineering, a female person of color like me found it hard to get into the door because I wasn't a typical computer science applicant. So interview processes designed for people who went straight from college into a tech job. Though this landscape is kind of changing with AI, but that's a whole other topic. Career changers, people of color, women, they're screened out at every stage. And here's the consequence that matters for us. When health equity tools are built by teams that don't reflect or include the communities those tools are meant to serve, those tools reflect the absence. The features that get built, the language that gets used, what gets prioritized, all of it is shaped by who is in the room. That's why we created SEED. SEED stands for Software Engineering and Educational Development. It's a 6-month mentorship program that takes career changers from underrepresented backgrounds and trains them as production-grade software engineers by having them actually build the health equity tracker. So not just practice projects, not tutorials, real features that serve real users. Participants spend 2 hours a week in one-on-one pair programming with senior engineers like Ben, working directly on the HET code base. They learn the full tech stack, Google Cloud Platform, Python data pipelines, React.js visualizations, automated testing, the maternal mortality feature that we kept mentioning, that we saw in the demo, our seed participants built that. So then both pilot participants who completed the program received full-time employment offers. So 100% of participants receive full-time job offers. 85,000 users are being served by production code seed participants wrote. 5 international contributors have joined the open source community. But I want to highlight the key insight on the right side of this slide because I think it's the most important thing I'll say today. Addressing health inequities requires addressing workforce inequities in the teams building health tools. Who builds the tools determines whose needs get centered. And that's not a soft claim about representation. It's a claim about what gets shipped, what gets prioritized, what features exist, and which ones don't. Seed is our attempt to close that gap, to build a pathway into tech that doesn't require the credentials that historically exclude people never had access to in the first place. And finally, the library connection. Okay, I've been building to this slide because I genuinely believe this audience is one of the most important partners that we could have. Libraries are already information hubs. You already have the infrastructure, the computers, the programming space, the workshop capacity. You already have deep community relationships across socioeconomic and demographic lines that most institutions spend decades trying to build. And you already have mission rooted in equitable access to information. It's not a metaphor. That is literally what we are trying to do with health data. You are already doing the work. We want to give you better tools for it. The community trust that libraries have built is something that a health data platform cannot manufacture. But when you combine that trust with accessible, disaggregated data, that's when things get really powerful. So what does that actually look like in practice? Here are 5 concrete applications. Digital literacy workshops. Teach patrons how to navigate the HET, interpret what they're seeing, and download data they can actually use. This is an extension of digital literacy programming that many of you are already doing, and we can help you develop the curriculum. Community health forums. Partner with your local health department to host data-driven conversations about health priorities in your neighborhood. Libraries are a neutral space in a way that government agencies often aren't, and that matters for community trust. Reference services. Train librarians to help patrons find and interpret health equity data for school projects, advocacy work, or personal health questions. This is a reference skill, and it's one that will matter more as health data becomes more central to civic life. Civic engagement. Help community members use data to prepare testimony for city councils, school boards, state legislatures. This is one of the highest leverage things a library can do. You're not just providing information, you're helping someone show up to a policy conversation with evidence. And youth education. Health data literacy is a genuinely useful skill. Integrating it into teen programs teaches critical thinking about data in a context that's real and relevant to young people's lives. And we also have our What is Health Equity page on the website if you want to know where you can start. And then last but not least, replicable models and next steps. So everything we built is available right now for free. The full HET codebase is on GitHub under the Satcher Institute organization. The data pipelines are documented for adaptation to state and local contexts. The visualization components can be exported to other websites and applications, and we're actively developing train the trainer material specifically for community health educators and library staff. On the lessons learned side, I want to be honest about what we figured out the hard way. Center community voice from the beginning and don't stop. Consultation at the start of a project isn't enough. Ongoing co-design means community partners are in the room when features are scoped, not just when they're evaluated. Build accessibility in from day one. Retrofitting a platforms for screen readers or mobile users after the fact is expensive and incomplete. It has to be part of the design from the very first conversation. And plain language is not dumbing down, it's respecting your audience. Our users are smart. They don't all have MPH degrees, and they shouldn't need one to use a public health tool. And workforce diversity produces better tools. SEED is evidence for that. The maternal mortality feature is better because the people who built it brought their lived experience to the work. So before we get to the open Q&A, I want to pose 4 questions that I think are worth sitting with, and I'd love to hear from you on any of them. First, what barriers do you see in your communities to accessing and using health data? I've named some structural ones today, but you are all on the ground in ways that I'm not. Second, how might your library partner with local health departments to expand data accessibility? We're genuinely interested in building those connections, and we'd love to hear what you're already doing. Third, what concerns do you have about health data literacy in patron communities, and how might we address them together? So not every community's relationship with health data institutions is a trusting one, and that matters. And fourth, where do you see opportunities for programs like SEED in your regions? The model is replicable, and we'd love to talk about that. Okay, so we'd love to open it up now. And a few ways to stay connected after today. The platform is at healthequitytracker.org, or you can scan the QR code right there. The full code base is on GitHub. And if you want to talk about a partnership, a workshop, user experience testing, we'd love to hear that. And you can reach us at info@healthequitytracker.org. And I just want to say thank you again so much for your time and your work. The fact that you're in this room means that you already care about equity, and we hope the HET can be a useful tool in that work. And Ben, did you want to uh, do some Q&A or any closing notes? I'll stop sharing.
Yeah, no, thank you so much, Kim. Once again, sorry if the connection is a little bit under quality, but I've answered a couple of the questions in the Q&A. And if there are any other questions, feel free to type them in. And thank you so much, everyone.
I will say it might be helpful to answer those questions verbally as well. We do sometimes have participants that aren't reading through or using other things. If you guys don't mind discussing those too, I know you answered very thoroughly in the Q&A, Ben.
Yeah, I can address those. Is the connection any better now, or is it still
It's a
pretty
little
bad?
bit better. So if you want to give it a go, I think it'd be helpful.
Okay, great. Yeah, there's a question. We've gotten this recently. A lot of federal sites, including the CDC, have either entirely removed their databases or restricted access. In some cases, they've just changed around the configuration so that our pipelines broke, but the data was still there. But the most important thing to note is that our pipeline process, it first ingests the data from the external source and stores it on our own servers. And then we can process the data from our own servers, which means that regardless of whether the site that we're drawing from goes down, we still do have the data up to that point that we can continue to present. And I think importantly, we present that data through the tracker maps and graphs, but we also allow access for people to download the data so that they can do the work themselves and recreate our methodology and sort of check the work themselves, or maybe go a different direction with it. That's not to say that the federal sources going down isn't a massive problem. It is, but we at least can kind of be a temporary stopgap. And I guess this answer kind of can blend into the next question about how we want to expand the tracker. We think of it as expanding the tracker horizontally by adding more health conditions, or vertically by doing more with what topics we have and maybe trying to make it more useful for more people. So one way that we're expanding, we're actually merging with a sister institute at Morehouse School of Medicine that's focused on global health equity. And right now, you've probably noticed that all the conditions and the maps were only the United States. We're really excited about what it could look like to expand the tracker globally. Part of that would also allow us to go to the World Health Organization and other global data sources, maybe thereby avoiding some of the problems that we're currently seeing uh, with changing federal administration. And even before the current situation, that has always been in the back of mind for us, is that some people would say, well, why are you just recreating the data that the CDC always presents? And this is an extremely good example why, because as the administration changes, you can't be sure that the data is going to be available. You can't be sure that they might not take a new political tactic and kind of take down the data they don't like and put up some other data that might not be as rigorous. So I think we see ourselves in it as an important alternate voice that we, and in this case, we could represent some of that global data.
Thank you so much. I think that is a very thorough answer to both of those questions, and it's appreciated. Did anyone else have any questions for our presenters while they are here? No, I think everything was covered so thoroughly. That was a terrific presentation, and I want to play around with the tracker a little bit for my own usage for work. So if there are no more questions, I will go ahead and close out the session.
Actually, sorry, Alicia, I can't
Yes.
type a question into the Q&A because I'm one of the
Oh, please go
people
ahead.
helping to run it. But I do have a question that was, flagged earlier in the presentation on the how AI is reshaping your work. And I know that's like a big, big question, but I do think it's top of mind, especially for data equity people at this point. So just wondering if you could say a few words on that.
Yeah, I'll give my answer and then I'll let Kim address an AI project that she also spearheaded as well. So on the one hand, it's really accelerating what we can put out code wise. It's just easier and faster to code features that might have been a little bit out of reach for our small team, because our entire team is just myself, Kim, and then another guy, Eric. But we've been able to expand into some really fruitful partnerships, including we started a collaborative alongside two like-minded organizations in Atlanta, focused on gun violence specifically, and what can be done to reduce gun violence in Atlanta. And then we also just recently got pulled into a collaboration that's dedicated to wiping out cervical cancer in Georgia by increasing rates of HPV vaccines and other interventions. So we've been able to leverage AI just to very quickly expand our data sources and get some of that data in place, particularly because the bones of the tracker are there and are solid. So it's a lot easier to expand on. As far as the user experience goes, I'll let Kim address it a little bit more, but we have a feature that has not quite been launched, but it's been in demo mode for a while that our other colleague, Eric, has mostly been working on. And what it's doing, it's leveraging an LLM like Claude to, oh, Kim's going to be able to demo it. Oh yeah, this is the top secret behind the curtain world premiere, everyone.
Oh, wow.
I'm just so
Preview.
excited. Yeah.
Yeah.
I was able to do this project with Bubble.io. They have a no code kind of software uh, platform. So what I wanted to do is to be able to bring AI insights from our tracker into something like a mobile application, but it didn't work out with Bubble, and that's a whole other thing. But we were able to do is to take the data that we have on the tracker, and then we are able to show an AI insight of what are you actually seeing. So this is not live. This is something that Eric and Ben have been working on, and yeah, we so I just want to show you this little itty bitty sparkle up here. So what we essentially want to do is to be able to generate an AI insight, and not sure if you can see that very well, but so we use the Claude API, and then it's showing that between 1999 and 2019, the gap of maternal deaths widened dramatically. And so now it's just like, it's basically just summarizing what you see here on the screen. And it just makes it easier for, there's all different kinds of learners out there. For me, I'm visual, I'm also kinetic, but for people that need like a quick breakdown of what is this saying? I don't have time to like sit here and process everything. I just need to know, like, give me like a couple sentences. And so that's what we're doing here. And so we have that at different parts of the different data visualizations. Essentially, it's going to give out like a different kind of output here. But yeah, I think that's it's make with AI out there, there's good and bad, and there's lots to be learned about literacy and how to leverage it in the best way. But I think this was initially built for policymakers and for people in academia. And like I mentioned, we don't want people to need to have a master's in public health in order to be able to use this. Like people that are in grassroots, that have boots on the ground, I want them to be able to take a quick look at the visualization, be like, yes, this is what I need to show in an advocacy meeting. And yeah, so we're still working out the kinks. There's a lot of user testing. If anyone's interested in testing this out, we would love to hear from you. We'd love to run like some user experience, have some feedback from real people that is outside of our little engineering team. But yeah, this is kind of what this is like the good part is that I can show this to my grandma and be like, my grandma who doesn't speak English as her first language, and be like, Grandma, look at this. This makes sense, right? And she'll be like, yeah. Oh, yeah, I can read that. I get it. So yeah, super exciting. It just makes me like, really excited to ways that we can keep iterating on the tracker and to make it more user friendly. And, if anyone has any suggestions, please, like we are so open to hearing from community peeps. Yeah, just email us. I sent it in the chat. I hope that helped, Rachel.
That was great. Yeah, thank you so much for answering that.
Oh, I like how you mentioned using it for advocacy work. It makes me think too of just advocating for libraries as well and our useful part in this. So thank you. We don't have any more questions unless there's any from anyone who can't add to the question box. But I think we are coming to the end of our time together, sadly. So I want to thank you both, Benjamin and Kim, for being here today and for presenting all this wonderful information. Please reach out to them if you have more questions or you want to play around with some of the tools and see how we may be able to lend a hand. So thank you to our audience for attending. And as a note for us here, we are committed to ensuring that SRRT programs are diverse, inclusive, and free for attendees. And in order to do so, we rely on support from ALA membership and direct donations. You can help champion our roundtable's mission and commitments by donating at the link provided or by joining SRRT as a member. You can make a general gift or select the SRRT task force or award that you would like to support. Please help us maintain our high quality programming, the core values that sustain it, and our commitment to accessibility by making a donation, becoming a SRRT member, or helping to spread the word about our roundtable and events just like this one. So thank you for being here today. Our next session actually will be starting in a little while, and that is going to be Beyond Access, addressing social isolation and mental health in underserved older adults through community-based engagement. And that will be starting fairly shortly in about 15 minutes. If anyone would like to join us, please do so. Otherwise, we hope to see you at one of the other sessions, possibly between the rest of today and tomorrow. So thank you so much for being here. Thank you both again for all the wonderful information, and we appreciate it.
Thank
Yep.
you.
Thank you so much.